Welcome everyone to the Resnik Grand Rounds, Wednesday, March 11th, 2026. As always, we have Dr. Hussein Tarek, our everyone's favorite prosthodontist and treatment planner and the clinical director of ITX Pros. He will be on. He tells me that we have approximately 14 arches to go through tonight, and we have some really good cases. So we're going to get to that ASAP. As always, we also have Dr. Rick Robinette, our clinical director at the Resnik Implant Institute. Rick will be on and he can answer any of your questions through the chat line. So if you have any questions on my little lecture that I give or any of the cases that we go over, please, through the chat box, ask Rick and he'll get right back to you. With that being said, as always, I give a short lecture on a hot topic or a controversial topic. And the one I'm going to talk about tonight is something that has really changed in our profession, and that is recognition or identification of dental implants. As you've probably been frustrated over the years, sometimes it's hard to determine which manufacturer, which system, even what size these implants are. In the past, uh, a lot of times we use records to see exactly what the implant is. Hopefully, the records are accurate. But now, with millions of implants being placed, and sometimes patients get lost, so there's no traceability back to what type of implant it is. And our patients move, and sometimes they need maintenance or repairs on these implants. So it is a problem. If we look at some of the challenges, there's more than 1,000 implant systems out there, more than 3,000, 4,000 implant designs. So there's a lot of implants to try to identify. Why do we have to identify these? Well, a lot of these implants do become discontinued, and a lot of people aren't even aware of them. Implants have been placed now for almost 40 years. So we have a long history of these implants. And if you don't recognize it, sometimes it's very difficult to find out exactly what um, implant it is. Secondly, a lot of times we don't have good radiographs of the implant to identify. So we're going to talk about that tonight. If we have an implant case that comes in, we don't know what implant it is, the best way is the records. Uh, find out from the patient's previous dentist what type of implant. That is probably the easiest. Second is radiographs, getting good radiographs, and then using databases or a lab to help you identify it. If we look in the past, we've used this probably for 15 years, whatimplantisThat.com, where you can go on and you can do it yourself, a free service, or you can pay them to attempt to identify the implant. One better that I think really works out, it's a lot easier to use, is Preet.com, where what they'll do is they'll identify the implant and they also sell the parts. So if you have to purchase any parts, it makes it a lot easier. However, this is all changing. And how is it changing with AI? There are AI systems now. There's two specific ones out there. This is implantif.ai. It's the largest database out of any company. It usually will identify the implant in less than 60 seconds. You can use your phone to do it. And as I said, it has the largest cloud system, so they have a lot of data to utilize. How does it work? Well, they have a free plan. You can identify two per month, and that's their free plan. And then if you need a more than that, then you can purchase a subscription. So that is one. Another one, spotimplant.com. This is a newer one, and this one is nice because they will actually accept CBCT images. Most of the AI companies out there want a periapical or a bite wing. This company actually will take a CBCT. CBCTs, it's early on their learning curve. In the future, that will change that all these AI companies will be able to identify from it. But right now, this is the one in particular that's very good for it. Secondly, this company acts as a marketplace. So they'll tell you what parts you need, and they'll actually link you to that company, whether it's an OEM part or a compatible part, to get the parts. If we look at some of the problems that we have with identifying, right here, you can see on the left, that is a good implant radiograph where you can see the threads, you can see the design of the actual implant. The one on the right is not good. It's blurred out. You can't really see the thread design, probably impossible to actually design. So if you are going to have one identified, try to get a X-ray like the one on the left. And here's another one. On the left, this is not a good one. Very, very difficult. Sometimes they can be identified from the internal configuration, whether it's a hex or a conical Morse taper. And then sometimes even like the apical flutes, you can use that to identify it. But if you have one like on the right, where it is perpendicular to the long axis, it's very, very easy for that to be identified. And what's the future? Now, there are companies coming out um, early on their learning curve with intraoral scanning using a CBCT and AI. So this is only going to get better. If we look at some of the studies, this is a systemic review. These AI companies, identification companies, are about 93% accurate, which I believe, what implant is that? They're probably anywhere from 50 to maybe 75% accurate. Here's another one, 94 to 98% accurate. So you can see they're a lot more accurate than us trying to identify it ourselves. So in summary, it's here to stay. AI is coming in all parts of implant dentistry. However, there's one issue that I want to bring up real quick. And even if we identify the implant, we still have an issue. And this is a add-on to what we talked about at last month's grand rounds with the OEM versus compatible parts. We're seeing more and more of these compatible parts. So let's say that even if you do identify the implant, and as an example, I have a Nobel BioCare. We're thinking that we're using a Nobel abutment. So we're going to use a Nobel wrench or implant driver to remove that screw. But there are some companies out there that do sell the compatible parts with a different thread design and different implant drivers. So you have to be very, very careful. So if you use these compatible parts, make sure you document that in your notes so that if someone does need to ever take that prosthesis off, they know the exact driver. Because what you don't want is someone thinking it's an OEM part and then it's actually a compatible part, but they're going to use an OEM driver and it's going to strip your compatible screw, and they'll strip it or even fracture it, and then you're at a significant problem. So again, identifying is one part of the problem. The more, though, of the use of these compatible parts, it's going to make it more challenging in the future. So with that being said, Hussein, I know we have all these cases. Let's go ahead and go to the actual cases. So thank you.
Always
And
a
who's
pleasure, always a pleasure, Professor. So first case we've got for today is for Dr. Shannon Taylor. Doctor, would you mind unmuting yourself and presenting your case to Dr. Resnik, please?
Hi, Doc.
Hello.
How are you?
Hi, I'm good. How are you?
Good, good. I believe you're on vacation, so you're
I
very
am.
dedicated. Okay. So
I am.
so let's go over your case. So let's do one side at a time. You want to do the left side first? Okay.
Sure.
So tell me about when were these teeth extracted?
3 to 4 years ago, she couldn't remember exactly.
Okay, so you didn't extract them.
No.
Do you know where they grafted?
Yes, they were.
They were okay. So
They were.
right off the bat, let's show everyone how Dr. Hussein, let's do an occlusal view. Let's remove the teeth. And I always like to see what we're looking at with horizontal and then vertical bone loss. So if we look on the left side, we have a little bit of buccal resorption. On the right side, there's a lot. So that
Mm-hmm.
whole ridge has significantly moved. So let's
Mm-hmm.
let's again let's start on the left. Hussein, did you work this up?
Yes, sir. I did add an
Okay.
implant at the side of number 19. So for number 19, Professor, what we're using over here is a 5.0 by 8 millimeter hand-tapered implant. The bone is deficient to the facial and to the lingual aspect, sir.
Okay. So what Hussein did is he just put a default implant in. We like as a molar 5 millimeter implant at the minimum because we're replacing usually a 10.5 millimeter mesial distal diameter tooth. So with that being said, um, Shannon, I think you have plenty of room. The nerve is not going to be an issue at all in this case because, as you can see, it's almost a type 3 nerve. And so it's very low, and you have a sublingual undercut there. So
Mm-hmm.
we have more of a problem with the undercut than the nerve. The issue that I have with this is if you can see, uh, Hussein, you're that in the central fossa. Can you put that a little bit more towards the lingual cusp?
Yes,
Just
sir.
angle that a little bit. Okay. Does that help? Not really. Okay. So, Shannon, as you know, we like to have at least 2 millimeters of bone on the buccal, one on the lingual. So, how much bone do you have? You have 1 millimeter there. Is that
To
Hussein?
the facial and zero point 0.6 millimeters to
Mm-hmm.
the lingual,
Yeah.
sir.
So, let's move the implant to the side. Let's just look at the site without the implant in. Okay. So Shannon, a couple things I don't like about this is it looks like if this was grafted 4 years ago, I doubt if they used allograft because it looks like there is some bone graft in the center, but you have two radiolucent areas. Um, it,
Right.
okay. So I it's probably like a xenograft they used and that's
Mm-hmm.
really poor bone quality. So
Mm-hmm.
my concern on this case is if you go ahead and start drilling and go ahead put the implant back in,
Yes, sir.
I think what you're going to find is that when you drill into this, it's going to be really soft. It's probably a
Mm-hmm.
combination of hard and soft tissue. So it's really iffy if you could get the implant in, and then you would still have to graft the buckle. So
Right.
this could be done. What I would do, probably the safest thing to do, Shannon, would be to tell the patient you're going to do your best to place the implant. Once you drill into the bone, if it is soft, like I think it's going to be, if that is actually not even bone at the superior aspect or the crestal part, you're going to have to remove that and graft it. So
Okay.
my gut feeling is you're probably going to have to graft this, which is probably not a bad idea anyway, because you could build out that buccal plate a little bit more, and then you would have a slam dunk implant later on. Okay. So you have two
Okay.
options: place the implant and graft it, or don't place the implant, graft it, and then delay the implant placement. Does that make
And
sense?
yes, you're also suggesting some ridge augmentation on the buckle, correct?
Yes, yes.
Yes.
So what I would do is just put what probably just even 1/10 screw there. And
Mm-hmm.
I if you do have to remove this bone, it's probably going to be a concavity. So it'll be an easy graft case.
Yeah.
But that just doesn't look right to me. At 4 years,
Mm-hmm.
the remodeling process should have taken care of that. Okay.
Yeah, she's also the one, if you remember her medical history, she's been taking the Stelara and the Otulfi, and now she's on Stargemza, so they keep changing it. It's all the same kind of thing now.
Yeah, so I did I send you that biologic
You
consent
did,
form?
yes, thank
Okay,
you.
make
Hmm.
sure you use that because the biologics you have to be careful of those. So
Yeah,
yeah, so there are some systemic issues here too. But
right.
as long as you inform what you don't want to do, and for everyone else on um Shannon has a lot of experience with this, but if you're early on your learning curve, you never want to get the patient's hopes up that that implant is definitely going in. Always let them know there's option B is going to be grafting. You're not going to do anything that's going to be unpredictable. You're going to do what's best in the patient's interest. And then if you have to graft, they understand. You don't want to
Hmm.
have to explain that afterwards. So, okay. So
Okay.
let's look at the other side. What do we
Yeah.
have, Hussein, on the other side?
So for the other side, Professor, we've got two implants at the size of number 29 and number 30. For number 29, Professor, I'm using a 3.5 by 8 millimeter long implant. As you could observe over here to the facial aspect, we're covered with very thin bone coverage to the facial
Hmm.
aspect, Professor.
Okay. Yes. And let's look at the other one.
30, I'm using a 5.0 by 8
Yeah.
exposed to the
Yeah. That
color of the implant, sir.
okay. So Shannon, that's going to be almost impossible to do unless you graft it. So I would do a graft and then delayed implant placement on these on this side. Definitely.
Okay.
Okay. You could try to place it and build up the bone, but that's going to be very unpredictable. And
Right.
your margin of error is so small here. It's that I think that would be a problem. So I would graft it, build it out to division A, and then go back and place the two implants. You'll have plenty of room above the nerve, and I think you'll probably be even a little bit higher after you build out the buckle there. So I think it'll be advantageous. Okay.
Can we look at that from the buccal view? Because the mental foramen it came up pretty high on my CT scan when I was for number 29.
Oh,
And
29. Okay. Let's
and
look at it.
it was really close. And that was one of my concerns with this case also.
Yeah. So that's an 8. Okay.
That's an 8,
So,
yes, sir.
It's an
yeah.
8.
Yeah. So can you measure that? How far you have?
Right now, Professor, we do have it at
One
exactly
point.
two
Yeah.
millimeters,
So
sir.
let's bodily move that implant um a little bit more to the lingual.
A little bit more to the lingual. You got it, sir.
Yeah. Okay. Now tilt it back so the apex goes lingual. Okay. Now push the crestal part forward. Okay. There we go. Okay. Now measure it again.
Here we go. Same exact measurement,
Hmm.
Professor.
No, you're going to
A
have
little
more.
more.
Yeah, you're going to have more.
2.4,
Little more.
sir.
2.4. Yeah. So you'll be fine. You'll be
You can play
that.
around with
Yeah.
it.
Well, if you have more width, you
Yeah.
can play around. The only thing I would do is do this guided,
Oh,
because
absolutely.
yeah, you have little margin there. Let's go. I forgot that I didn't have time. Let's go back to the other side real quick. I just want to mention
19.
it for all the. Let's look at the 3D image.
3D image right away, Professor.
Okay, and let's look at it from the side view. Okay, get rid of the implant if you could. Okay, and then this is another one. When you're doing the prosthetics, you want to do a guide plane on these. So see how that second molar is a little bit tilted.
Hmm.
um, and it's not parallel to the bicuspid. So do two guide planes, parallel them, and then you have one path of insertion for the crown. You want to do that prior to the prosthetics. So that is how you avoid having a contact open up. And number two, it
Hmm.
allows you to put the crown in seconds instead of adjusting. So just for everyone
Okay.
else on the call, I know Shannon knows that one, but I did see that before. So anyway, okay.
Thank you.
Any other questions?
No, thank you very
Okay.
much.
Okay, great. Let's go. Who's number two?
Next case, Professor, is for Dr. Haley. Doctor, would you mind unmuting
Mary.
yourself?
Hi, how are you?
Hi, Mary. Okay, are you gonna have an easy one for us tonight?
I hope so. My patient is very motivated to get started. He's 35 years old. He
Okay.
used to not be very healthy, but he's lost weight. He's got his health concerns under control, no more smoking, things like that. He
Okay.
is missing numbers 7 through 10. He's been wearing a
Okay.
partial for 10 years.
Okay.
Um, he has a very low smile line.
Okay. So aesthetics isn't a problem. How about force factors on this gentleman?
I think he has a pretty solid bite. So they worked the case up already with 2 implants versus 4. So I
Okay. So, could you define solid bite for me?
class 1 occlusion, but he does have wear facets. I took some intraoral pictures of the bite and there's space.
Okay.
You know what I mean? I don't know how to describe it.
Was this trauma? He lost these teeth?
I think it was trauma. I don't know the history of it.
Okay. Okay. And how about number four? Were you looking to place an implant in number four?
Not at this
Not
time.
at this time. Okay. So Hussein, tell us what you did for us.
So we did add 4 virtual crowns, Professor, at the size of
Okay.
7 to 10, and I did
Can we
add
do a
4 implants.
360 on that just so I can look at them
Absolutely.
from the front? Perfect. Nice job. Okay. That's good.
Four
Okay.
implants, Professor, 3 O's at the sides of the lateral incisor, and 3 5 implants at the sides of 8 and 9. Right now, I'm presenting the side of number 7, where we do have a 3O by 11.5 millimeter long implant. As I rotate around this implant, sir, I do have 1.5 millimeters to the laminate dura of the adjacent tooth, a little bit more. Yeah, just a tad
Okay.
over here.
So Mary, don't worry about that gutta percha. Once you perform your osteotomy, you'll get rid of that. So that will be gone. So don't worry about that.
AIDS is our
Okay.
next one, Professor, where we're using a short implant over here, a 3.5 by 8 millimeter long implant, sir.
Okay.
Clear away from the nasal palatine canal, 3 millimeters in between 7 and 8. And then we've got number 9, where we're maintaining 3 millimeters of mucosal space in between our implants. That's a 3.5 by 8 at the side of number 9 as well, sir. And the reason why they're turning red, Dr. Resnick, is only because of the apical tip of the implants, but at the
Yeah.
flat, we've got plenty. That is our next one, sir, where we're using a 3.0 by 11.5 millimeter long implant, adequate bone coverage to the facial and to the pathos, sir. Rotating around this one, clear away from the laminatura of the adjacent tooth, 3 millimeters in between number 9 and number 10, sir.
Okay. So Mary, do we have the mandible on this?
Um, I got it as a volume render, sir. We did not segment the
Okay.
mandible.
So just look. So he has a little bit of mastoid hypertrophy. Okay. Okay. So a couple things. Number one, Mary, do you see where those implants are coming out? So this is not wouldn't be able to be screw retained. So this would
Okay.
be cement retained. If you want to do screw retained, it would have to be a graft case. So you would have to graft it.
Okay.
Uh, there's no problem in doing a cement case. It's just a little bit more difficult to do because you're going to splint these anyway. Now the question is, how many implants do you do? Uh, you always want a 3.0 in the lateral because remember a lateral 6 millimeters mesial distal. A 3 millimeter gives you 1.5 on each side. That three plus 1.5 equals 6. So that's perfect. Um, However, the bone quality here is not that great, and the bone volume is not that great that I would be more apt to possibly do all four of these implants. He does have some mastoid hypertrophy. Male does have a stronger bite. With the anterior guidance and everything, I think it would be safer to do 4 implants. Certainly, you don't want to do two. A compromise would be to do 3 implants. If that was the case, I'd probably not place an implant in 9 because 9 was a little bit thinner on the buckle. Uh, but I think probably the safest would be to do, was that, or maybe 8. Check 8.
I think it's number 8, sir.
Nay,
9 is
eight
a.
Eight.
was okay. 8 was a little bit thinner. Um, See all the cortical bone there, though? I think you would be fine. Even though you don't have 2 millimeters there, you have really thick cortical bone. But do you see the bone density? The cancellous space is very, very poor. So this is going to be like D3, almost D4 type of bone. So when we look at the number of implants, we look at force factors and then also the host sites. So the host site The negative is the poor bone density. Okay. So I think this would be easy to do as a guided case. If you want to do it screw retained or cement retained, if you want to do it screw retained, then you would have to probably graft it.
You couldn't do angled screw channels
Well,
or
you could, but it's now you're going to lose vertical space, or you're going to need more vertical space. Hussein, just can you angle that one? Take the apex, a little buckle. Maybe we can get it. But you know what? I would yeah, put the apex more buckle there. Okay. You know what? You might be able to do this. Mary, you know what? We don't have time to do it tonight, but let Hussein do his magic. See, that's the 11 and a half. Okay. I bet you could almost get that, Hussein. I think
I
you
think
might
I
be.
can, sir.
Yeah. Mary, let him play around with that, and he'll get back to you on that. Okay.
okay.
But
Thank you so much.
does that make four implants? Do you see why we have the four on this case?
Yeah, I met with the patient yesterday. I was recommending 4 versus trying to do 2 with a bridge because
No.
and I even asked about doing 2 3.5s. I'm like, I just don't
No, because if you do two 3.5s, now the laterals are going to be
too wide.
wider. Yeah, aesthetically, it won't look good. And
Okay.
you don't want to do two in the anterior and cantilever. So you almost need all four. Yeah.
Okay, so
Uh,
no implant bridge splint everything.
Splint it. And I think he can get you into a screw retained.
Screw retain with an angled channel maybe or
No,
we're
I
not doing
think he can do
regular.
it straight. Yeah.
Okay,
I think
because
I
if I
can,
can
sir.
do that, I would prefer.
Yeah.
I'll do
I
whatever you recommend, but
he's good. He'll do it. He'll get
thank
it.
you so much.
Okay, Mary, take care.
Thank you.
Okay. Okay, Hussein, who's the next?
Dr. Karan Bahandorkar is our next case professor. Doctor, would you mind unmuting yourself and presenting your case to Dr. Resnik, please?
Hi, Doc. How are
Uh,
you?
I'm good. How are you doing, Doc?
Good, good. So tell me, what do you have for us tonight?
So we have a 65-year-old patient. I think we did an extraction on tooth number 8 a few months ago. We did put in a little bit of bone graft as well. He had dent partials before and he wasn't too happy with it. So right now he's looking at getting tooth number 8, um, getting an implant on tooth number 8. I am trying to talk him into getting more on the left side as well, but as of now, he wants to focus on 8. He is a diabetic and he does have, I think his A1C levels was around 7, from what I
Okay,
remember, and blood pressure and cholesterol. He is on benzapril, amlodipine, atorvastatin, 500 milligram of metformin, hydrochlorothiazide, and he's on 2 milligram of Ozempic as well.
okay. So he has some heart issues and he is a diabetic. So,
Mm.
okay. So right off the bat, let's look at the X-ray on this. Look at a
Yes, sir.
pan. Let's see what we're actually looking at here. So the condition of these other teeth, how are these other teeth? Are they all restorable?
Uh, I they he does have a lot of bone loss, but not a lot of mobility on them.
Okay. So I'm looking at some pretty significant infections over on the right side. Okay.
Yes.
Hussein, why don't we do a cross section? Start at number 2.
Right away, professor. Here we go.
Okay.
So
Is
that's
that
number
2?
3.
Okay.
That's tooth number 3, sir. With
Okay.
appropriate
Let's start at
pathologies.
2.
Here's number 2, sir.
So 2 looks like there's no bone. Okay. Keep going. Okay. 3. Keep going.
4 with
4.
pathology over here, sir.
4.
5 is our remaining root.
6. There's almost no bone. Okay.
7.
Wow.
Then our side is over here at 8. Then here's number
Oh, it's
9 with an
9.
infraction over here.
And there's
Yes,
no
sir.
buckle
Mm-hmm.
bone on it. Okay.
Yeah.
Okay. So, Doc, let me tell you, let's go back to the 3D image. Okay.
Mm-hmm.
Um, the last thing this patient needs is just one implant.
Yes.
Sorry to say that.
Mm-hmm.
And I'm going to say his dentition is guarded to very poor.
Mm-hmm.
Okay. He has
Yes.
infections. You're going to lose those posterior teeth. So you're going
Yes.
to lose 2, 3, 4, and 5. Number 9, 6, 7, and 9 have no bone on the buckle.
Mm-hmm.
And number 15 is not good either.
Yes.
Um, I would, I think it would be a mistake to put implants in number 8 and then
Mm-hmm.
just treat. I think you said 10 through 13 or 14 you were looking at.
Yeah.
Um, I think that would be a mistake.
That's like,
I would say that if he wants an implant prosthesis, it would have to be a full arch
okay.
prosthesis. To do that, you're going to have to extract the teeth first,
Mhm.
remove all the infection, graft it, and then come back and treatment plan for a full arch, all on X case.
Okay.
Okay. Does that make
Mm-hmm.
sense?
Yes.
Because if you look at the condition of these teeth, that
Mm-hmm.
they're not good at all. So you always want to look at the infection.
Mm-hmm.
And remember, implants are elective. So we always have to treat the infection first. And by treating all that infection and the perio disease,
Mm-hmm. Mm-hmm.
I don't think you're going to have anything left. And
Left.
then you look at what the occlusal table looks like, what type
Mm-hmm.
of function he's going to have. I think the best thing would be to remove the teeth.
Mm-hmm.
Okay.
Okay. Yes. Yeah, that's what
Okay.
I was thinking as well, but he was like
Okay.
adamant on that. Yeah.
Yeah. So now you have to re-educate him,
Yes.
and whatever you would try to do would not last.
Mm-hmm.
And just tell him that I could do it, but it wouldn't be fair to you. So
Yes.
a lot
Yeah.
of times they'll understand that then. Okay.
Mhm. Okay. Thank you.
Okay. Take care.
Take care.
Okay. Who is
Dr.
next?
Jerome is our next doctor, Dr. Resnik.
Okay. Dr. Jerome. How are you?
Hey everybody, how's it going tonight? Can you
Good.
hear me?
Good. Yeah. Perfect. What do you have for us tonight?
I have a 73-year-old male that is looking to replace number 28.
Okay.
Tooth was extracted a few years ago. He has a handful of all different types, shapes, and kinds of implants in his mouth right now. But we're focused on 28. I'm a little
Okay.
bit skeptical on the bone available,
Okay.
specifically buccal lingual. So I just wanted to get an opinion here.
Okay. So, Hussein, is that coming up? Okay, there it is.
Here
Okay.
we go, Professor.
So we're looking at 28. So right off the bat, Doc, let's remove the teeth. Okay. See how you lost buccal bone right off the
Yep.
bat? Now, in this area, a lot of times that doesn't matter so much because you have so much volume that sometimes we can work around it. This one's going to be really close though.
Hmm.
So let's go ahead. Hussein, did you work this up?
Yes, sir. I did add an implant at the side of number 28. Right now, Professor, I'm using a 3.5 by 10 millimeter implant at that side, and I'm going to switch off the bow mask for you to check, sir. So we're exposed to the facial aspect over here, Professor. And as I rotate around this implant, we're clear away from the mental frame and the
Yeah, but
anterior lobe anatomy and clear away from the adjacent teeth structure, sir. But augmentation will be needed, Doc.
I,
Yeah, that's
I
what I was thinking.
yeah. What is the what's the history on this again? This was grafted.
Tooth was extracted, I believe, a few years ago. So I
Okay.
don't have a perfect history on it. It looks like there's a little bit of endosealer or gutta percha down there.
Okay. Uh, um, do a 360 on this one, Hussein. Yeah. Okay. I won't worry about the sealer. That's not going to affect the implant. I'm more worried about this facial defect that you have here. It almost
Yeah.
looks like a bony a track. So you have a crevice there. Um, Hussein, can you raise that implant? And is that scan, is that a little motion? Is that why we can't see the upper that well?
It's because of the beam hardening, sir, with the multiple different implants we got over here. It's affecting the quality of the image that we're checking out.
Okay, so take the apex. Let's bring a little buckle. Yeah, the opposite way. So grab, yeah. What I'm trying to do is angle it away from this
Yeah.
defect. Okay, keep going, keep going. Now bring the apex buccally. Okay, now bring the whole implant bodily, one click into your buckle. One more. Okay. Now, we can we see any more of that upper tooth?
Um, yes, sir, we can.
Okay. Okay. That's actually in pretty good alignment then. So that's on the lingual cusp. So, Doc, here I think you can do this. Uh, the only issue I have is what you're going to find in there. The scan has some artifacts there that
Hmm.
it's not giving us the clearest picture. Uh, so one option would be to retake this scan
Okay.
and just go to the occlusal of the lower. Don't take anything of the upper
Okay.
so that we don't get any scattering from the upper and try to get a better representation of this. However, I think that you'll get primary stability on this. The worst scenario is that you would have to graft this buckle.
Okay.
And you could use the bone from the actual osteotomy and then a little bit of allograft and put a little collagen membrane on. I think you'd be fine.
Okay.
Okay. So I think where he has it there would work. But do you have a scanner yourself at your office?
Yes.
Okay. I would try to do that. So again, just collimate it so the upper's not in the scan.
Okay.
And because Hussein, do you agree with that? That there's just
Yes,
so
sir.
much scatter here that,
You're
yeah.
yeah, what you're saying, Dr. Resnick, is perfectly aligned with what we're gonna need. Yes, if we could separate the upper and not even include the upper, if Dr. Jerome does have an intraoral scanner, he could export the upper and the lower, kind of an occlusion, the iOS, and we could use the upper records of the intraoral scan to properly align our implants to reflect with the antagonist tooth onto the opposing arch, sir. So we
Does
don't
that
Okay.
need the
make sense?
upper.
It does. Yeah.
Yeah.
It does.
Okay. So let's do one last thing. Go to the 3D image.
Yes, sir.
Sometimes you'll get to see that on the 3D image. So that now bring it over so we can look at sagittally from the
Sagittal.
side. Yeah. Yeah, I have a feeling you're going to grab that, but Doc, do you remember the catcher's mitt?
Hmm.
You have one big catcher's mitt there.
Okay.
That'll be the easiest graph you'll ever do.
Okay.
Yeah.
All right. That
But
sounds good. That's kind of what I was thinking. I appreciate it. Thank
yeah,
you.
yeah, but I think you'll get primary stability. The only way that I would abort that is if you put the implant in and you don't have good primary stability. But I think if you do this guided, I think you'll be fine.
Okay.
Okay?
Awesome.
Okay, take care, Doc.
All right. Thank you guys.
Okay,
Thank you.
okay. Uh-huh.
Next case,
Okay,
Dr. Resnick. Dr. Fatima, sir.
okay. Dr. Fatima, how are you?
And I'm just checking on her, Professor. Fatima.
Is she on?
Yeah, I think we're gonna skip to the next one, sir. It's gonna be Dr. Gupta. No, it's gonna be Dr. Shirk, Dr. Jake Shirk, our next one, sir.
Okay. Dr. Shirk.
Hello.
Hi, how are you?
Doing well. How are you?
Good, good. What do you have for us tonight?
I have a new patient to me, 52-year-old male, basically in terminal dentition,
Okay.
kind of uneven occlusal plane, anterior edge to edge bite. Talked to him
Okay.
about totally edentulating him.
Okay.
Medical history wise, non-significant except for kind of high BMI.
Okay.
um, but no medications, no significant medical history.
Uh,
His main concern is a lot of broken off roots that are retained and super eruption of the opposing teeth.
okay.
Talk,
And
go
what
ahead.
was his age again, Doc?
52.
52. Okay. So, and you said you talked to him about edentulating him. Is that correct?
Yes. Yep.
And he was
It,
fine with that?
yep. He kind of expected it. Uh,
Okay. Okay.
Looking at the remaining teeth, there's only maybe four or five, but they're very compromised, even those that if it could save them on the upper and on the lower, it's mainly like 22 through 26, maybe we could save, or along those lines. So, but with the kind of super eruption and the uneven bone level, you'll see it's looking like we got to take everything out.
Okay. Okay.
So,
So on these cases, Doc, and you probably heard me talk about it, I always like to give the patient the option of even though they're terminal dentition, of keeping the teeth and knowing that they're not going to get better and he'll still have the problems with eating, you know, teeth breaking down, pain, et cetera, et cetera. But I get it, and the patient understands. However, just always give them that option. Can we see the
yep,
lower two, Hussein, or is
Absolutely,
it,
sir.
or do you
It's
have
a
to
different
open?
it's a different project. I'll open it right
Oh,
after we
then
go, Professor.
leave it like that. Okay. I just wanted to see what we were looking at. So there's only anterior teeth and then the posteriors are worn down.
Rem
correct. Yep.
Remaining roots pretty much, Professor.
Okay. Okay. So let's look at the upper pan view. Okay. So Doc, let's first look at what we have here.
So
Okay.
I always talk about removable with locators or with a bar, and then also with fixed.
Oh, perfect. Good. Good.
So
I
I've
love
already
it.
had that discussion with them the
Great.
first time, and then I brought them back in again this Monday to kind of rediscuss those options and to kind of
Okay.
talk through the whole process.
And
So
oh,
oh,
go ahead. I'm sorry. Go.
my latest discussion we're going to do is to take out the root tips and flatten off some of the bone where it's really just not healthy, and then wait until June to allow a lot of the bone healing and then go forward with the removal of the remaining dentition. But leaning more towards fixed based
Okay.
on the sinus and try I feel like the implants would have to be too far anterior to do locators that are parallel.
Yeah, locators. I think actually now it's a lot less expensive to do fixed anyway. So,
Yeah.
and locators would be difficult on this case.
Yep.
One thing I see is there's a lot of infection on these teeth. Why don't we do
Yep.
a quick cross section on these?
You
You
got it, sir.
saying?
So starting from the second molder, Professor, here we go.
Okay.
I'm gonna keep on scrolling.
Okay.
Tooth number three, remaining root with a pathology. Five, remaining root with a pathology. That's number six, caries. Seven, short root. Eight, I think that's eight.
Yeah,
Nine,
nine.
we've got a
Yeah.
Yep,
caries.
that's 9 there.
Okay.
Then 11 is a broken, 12 is a remaining root, sir. 13 is a remaining root. That's, I think, the remnants of number 14 over here. Then that's tooth number 15, Professor.
Yep.
Okay. Okay. So let's go back to the Panorex again. Okay. So, Doc, um, when let me tell you ideally how we like to do these cases. There's obviously different ways, but the maxilla, this patient has a compromised bite. So their vertical dimension is definitely needs to be reestablished
Yep.
because there's no posterior teeth on the bottom. So he's over closing. The condition of these teeth, it's irregular plane of occlusion. This the prosthetics on this is going to be the hard part.
Yeah.
Okay, even though the surgery is not going to be easy, but if I look at this, there's a lot of infection on these teeth. There's very little bone apical, so there's no way that this can be done immediately. So the only thing that I would suggest possibly is I know you said you were going to take some root tips out. Um, One option that was that on the bottom or on the top?
Both top and bottom. I was going to take out 4, 5, and then 12, 13, 14, and then on the lowers, all of the root tips, except for like basically the lower anterior, basically 22
And,
through 26 or
and
27, I think.
and then you said in June you would remove the rest of the teeth.
Correct. Yep. Because
Okay.
he wants to be sedated for the bone reduction and implants. So I told him the root tips are going to be a little easier to get out. A lot
Okay.
of them.
So let me give you another option, Doc. Okay.
Okay.
So phase one would be extract all the maxillary teeth under sedation or however you want to do it. Remove as much infection, graft the sites, especially grafting the cuspid sites, the molar sites, and the bicuspid sites.
Hmm.
Give him a upper denture. At that same time, make him a smile transition. It's like a snap-on smile on the lower and start to reestablish his vertical dimension because he's overclosed. He has force
Well,
factors.
his bite is actually edge to edge in the anterior. So everything that you see him being overclosed is actually just super eruption. Like his anteriors are edge to edge.
They are.
Yeah.
Okay.
He literally cannot get past edge occlusion. It's
Okay.
almost a slight three class three jaw relationship.
Okay. Is he always been like that? Do you
Yeah,
know?
yep,
He's
yep.
always been a class three and he's
It's literally like edge to edge. I'd say mild wear. I don't think I uploaded the STL file of his intraoral scan, but edge to
okay.
edge, but in the posterior, it's roots hitting super erupted teeth.
Okay. Well, no matter what, you're going to have to reestablish
Yeah,
all the maximum. So, just for everyone else on the call, this works really nice in that number one, you always work on the maxilla first because the maxilla takes longer than the mandible. Secondly, the tooth position of the maxilla dictates the anterior guidance, aesthetics, vertical dimension, all the maxillomandibular relations. So by making him a denture, you can not do anything on the lower, or you could do a snap-on and try to get him more in a class one relationship. And that just starts to train his jaws into a full occlusion. These patients have a hard time if you edentulate upper and lower because then they lose their centric, they lose their vertical very, very easily. So my thought on this was if you edentulate the top, graft it, put in a denture, in the interim, you're building the ideal occlusal table, centric and vertical, and then you can go ahead and actually, once you do that, you can remove these root tips, or you can even remove all the lower teeth and place the implants because you're going to have a huge osteoplasty on the
yeah,
lower that's going to be below all those infections. So if you have an upper denture that's aesthetically and functionally pleasing, you determine where the lower teeth need to be. Now you can edentulate them on the lower, put implants in, immediate load it, so then he doesn't have to go through a lower denture moving around. By that
yep,
time, the upper is ready for the implants. And then what happens is you can complete the case together. But he never has to go through a lower prosthesis or a full denture moving around because you've already reestablished that. If you start taking out teeth, the problem that I have is some days somehow you're going to have to develop an occlusion here. And it's easier if you do that during the healing period and if the patient doesn't lose their centric. So by doing one arch at a time, in that sequence, you kind of maintain his vertical that he has and his centric. And I think you then can put the teeth in a better position for aesthetics and function. Okay.
Okay.
Does that make does that the phases make sense to you?
Yep, makes sense. When you
Okay.
take out the upper, especially at 4 and 5, is where the infection's kind of right where I want to graft. Are you gonna take it out and graft the same day, or are you gonna take
Yeah.
it out?
So give me a cross section on 4 and 5.
Right away, sir.
So here's the rule of thumb. If you can get the infection out, doc, without going into the sinus or affecting another tooth, then you can graft. So 4 and 5, you'll be able to get that infection out, no problem. 4 is going to be a little bit more of a challenge. You just don't want to perforate up into the sinus. So use a serrated curette, and if you have to, you can use a round burr and a round acrylic burr. Okay, and then graft. If you can't remove the infection, then use a collagen plug. Remove as much as you can off the buccal, lingual, medial, distal. Just don't take the apical, and then put a collagen plug in and let the body heal it itself.
Sounds good.
Okay.
Yep.
Okay. If you need any help on that, doc, just email me because this one's a complex one, and I'll help you with the different phases on that. Okay.
Sounds good. Thank you.
Okay. Who do we have next, Hussein?
Dr. Salama is our next doctor professor. Dr. Salama, would you mind unmuting yourself and presenting your case to Dr. Resnik, please?
Hi, Dr. Resnik. How are
Hey,
you?
good. How are you?
Good.
Okay. What
So
do you have for us?
I have Michael. He's 46 years old. He has a bridge from number 17 to number 20, if I remember correctly, or 21. And I noticed that the bridge maybe debonded on number 17 with possible decay on number 17. So we want to explore the option if the bridge need to be taken out, if he can have implants to replace the missing teeth. Um, he's been missing these teeth for a long time. I can tell you the record from the office where I am now. He had number 18 extracted 2011.
Okay. So let's take a look at. So it looks like it's a bridge from
17 to 20, Professor.
17 to 20, 17 to
Yes.
20. Okay. So even though that's split, that's how the CT came out. So, okay. So let's remove the teeth. Okay. So right off the bat, Mary, do you see the
Yeah.
deficiency there? Yeah, that's pretty significant. So he's lost a great deal of the buccal plate here. And so let's go ahead and let's look at this in cross section. So why don't we start at number 20, Dr. Hussein, and work our way back?
Here we go, Professor.
So
So
it's
that's number
number
20.
20. Okay.
Yes, sir.
So Mary, 20's in good shape. So
Okay.
you could just leave a full coverage crown on that one. Okay. So
Yeah. The
let's look at 19. So we over 19, Hussein?
Yes, sir.
Okay. So see where the tooth is compared to where the bone is?
yes.
So that bone is going to have to be built out. So we're going to need some augmentation there to build that buccal plate out. Let's keep going back to 18.
Here is number
Okay.
18, Professor.
Okay. Now, the good news is, Mary, do you see how low that nerve is?
Yes.
So that's a type 3 nerve. Type 3 nerve is ideal for these situations because they're really low. But the problem is we're not going to we're going to need more of a buccal plate there to place the implants because the only way to do this would be to do a significant osteoplasty, but then the implants are going to be way too low, so the crown to implant ratio is going to be compromised. So if we go back to the pan view on this and just blow that up, okay. So Mary, do you see how the bone distal to number 20 sinks
Is
a
that
big,
down?
yeah, see how it
Yeah.
dips down? So you don't need that much. I wouldn't try to get height because I don't think you actually even need it, but you do need two implants and they need to be split together because of the biomechanics of it. But usually what we do is place the implant a little bit further away from the distal of number 20 so you don't lose the bone distal of 20. And Hussein can help you on that, but this is a really good case because it has a low nerve and you'll never even get close to the nerve. So I think it would be a good graft case for you. Okay.
Okay. Okay.
So,
Sounds good.
phase one would be ridge augmentation. It would be with tent screws. And then phase two would be probably 4 to 6 months after. It would be two implants. And then phase three would be two implants splinted together.
Sounds good. Sounds
Okay.
good. Yeah. Thank you.
Okay. Take care, Mary. Have a good night.
You too.
Okay.
Next
Okay,
case, Professor.
Hussein, who do we have?
Dr. Mangifico.
Okay, Doc. You always have good cases. What do you have for us tonight?
Good morning or
Hi.
good
Good
evening.
evening. Yes. How are you?
Pretty good. How are you?
Good. Good. So you have a good case for us?
I believe so.
Okay. Good. So
Um,
tell me about your patient.
77-year-old male. He has a history of COPD. He's on Trelegy, an asthma inhaler. Number 14 was root canaled less than a year ago, and it had problems even a month after it was root canaled. And they wanted to do exploratory root amputation.
Okay.
And so that's guarded prognosis to me. So we're
Very good. Yes.
talking about possibly taking 14 out and placing an implant after, sufficient healing and bone graft. And so I just want some input on that.
Okay. Okay. So let's take a cross section of this, Hussein, and
Right away, sir.
let's take a look at that. They
That's
won
the side
the
of number 14, sir.
they won the root amp this? Oh my gosh.
Yes.
You
Yeah.
gotta be kidding me.
Yeah. No,
Oh my
and it goes way worse than that, but
Oh my
that's a
gosh.
long story.
That's horrible. Okay.
Yeah.
That should never even be a thought. Okay. That's a shame. Let's go to the pan view of this. Okay. So, Doc, here's what I'm going to recommend. This tooth needs to come out. All that
Yes.
infection needs to be removed. I think you'll be able to remove it without getting into the sinus.
Okay.
The problem is going to be the aftermath. You're not going to have enough bone to place an implant there, and it's definitely going to be compromised in the height of where the bone is. So what I'm going to suggest is phase one would be to extract the tooth, remove all the infection, get good bleeding, graft it. This is one that I would definitely use cefazolin
Yes.
with the graft. Okay. Phase two is going to be a CBCT. Now, that graft, you're going to call it on your treatment plan a preliminary graft because you're definitely going to have to use or you're going to have a post graft on this. So you're going to have a secondary graft into the sinus, whether it's an SA3 or an SA4. We won't know that until after everything heals. But there's been so much bone destruction there, Doc, that it's definitely going to need a second graft. However, I would not just place one implant. I would treatment plan two implants
Okay.
and splint them together. The reason is you have, a third molar occlusion on the lower, and one implant would just get beat up there. So biomechanically, it's going to be a lot stronger placing two. And this is probably the easiest time to do it when you give them the treatment plan. So phase one, remove the implant, um, preliminary bone graft. Phase 2 is going to be a CBCT 3 months after that. You're going to
Okay.
evaluate it. That's going to determine if you're going to need an SA3 or an SA4. That will be your sinus graft. And then phase 3 will be 2 implants in that area that will be splinted together.
Okay.
Okay.
So I guess the only thing that I was concerned about is whether I should graft the site at extraction.
Yeah. So let's look at it again, Hussein.
Yes, sir.
I didn't. Now, if the roots are into the sinus, we don't like to graft at the same time.
Okay.
So let me see. I thought you had a good cortical. Yeah, you know what? I think you have cortical bone there.
Okay.
So even though it's not, you're going to gain a little bit, but it might be enough to prevent you from having to do an SA4. You might just
Yeah.
have to do an SA3. That's my thought on it.
Okay.
So I think just be careful. You'll be able to see that,
Yeah.
but use a serrated curette
Mm-hmm. For
in
Lucas.
Lucas into that lingual bone, just decorticate it, get some good bleeding there, and then definitely use antibiotic in the graft. And I think
Perfect.
you'll be good on this. Uh, on this particular graft, I would recommend osteofiber. You've used that, right, in the labs? And
Yes.
yeah,
It's almost like a sticky bone type
that's the
situation.
putty. Yes.
Yes. Yeah.
The reason, Christine, on this is if you use particulate, it's gonna go everywhere.
Everywhere. Yeah. I
And
got.
just use osteofiber. It'll work a lot better for you. And again, I think that's enough to increase our chances of only having to do an SA3.
Yeah. Okay. Perfect. That's where that's exactly where I was at. So.
Oh, perfect. Good. Good.
Yay.
Just make sure you get medical clearance. The patient has COPD, a bunch of inhalers. Just make sure he's 77. Just make
Yes.
sure that he is medically, systemically stable to have that done.
Okay.
Okay.
Awesome.
Okay. Take care, Doc.
You as well. Thank you. I
Okay.
appreciate it.
Okay.
Bye.
Okay. And who's our next
Professor
one?
Dr. Winter, and till I load the project, sir, Dr. Winter did share with us a few pictures that he wanted to present to you as well. So I'm going to start with this. And Dr. Winter, please go ahead and present your case, Dr. Resnik,
So
please.
Dr. Winter has never had an easy case. So I expect this one to be on a scale of 1 to 10 of 15.
No.
So, okay. So what do we have, Doc? A high smile line?
Thank you for the opportunity to present this
Okay.
case, Dr. Resnick. Yes, she does have a high smile line, presents 48-year-old Caucasian female, presents with a chief complaint of poor fitting upper partial. She just doesn't like the aesthetics. She's got a real deep bite, maxillary tori, mandibular tori. But the main reason I'm presenting this was when Hussein brings up her CBCT, she's got an impacted canine. And I
Okay.
was
Oh my
curious.
gosh.
Originally, I was thinking about an RP4 for her to reestablish, but he'll show you what we're dealing with there. So I was just kind of curious, really, how
Yeah,
to manage this case on out. The existing implant is fine, so I'll let you take it from there.
okay. Um, Hussein,
Axial, sir?
yeah, let's look at the cross sections of this. So Dan, let's see where this tooth is in relation to our edentulous area here.
So I'm
So,
starting at the side of number 2, sir, right now. And here's number 3. We've got a
okay.
pathology related to this
Okay,
one.
Dan, you see that pathology?
Yes,
Okay.
sure. Yeah.
Okay. Okay.
That's number 4, sir.
4. Wow, they all have it. Okay.
And then our impacted canine is going to start
Okay.
appearing neatly toward it doesn't cross the midline, Professor, but it's like the crown is exactly where tooth number 8 is.
So we have some external resorption there, Doc, on the root of 8. Okay, keep going.
Yes.
Keep going. Wow.
And
Nine are
that's
not.
number 9, sir.
They're not in good shape.
Wow. Okay, Dan, I was wrong. It's not a 15, it's a 25 out of 10 difficulty. Okay. So let's go back. let's first talk about these other teeth. Are there's pathology on some of these posterior teeth? Is that being addressed, or is what's the prognosis? Do you know of these teeth?
Oh, I think the prognosis on them is poor, to be honest with you. The anterior teeth, the prognosis was poor, and with her deep, deep bite, I just don't like her occlusal plane. She also doesn't have much restorative space. Anything fully removable in the upper with her maxillary tori, we were we were leaning away from that. So I'm not, and I don't think the patient either is opposed to at her age edentulating the maxilla in an effort to
Okay.
move towards,
Okay,
like
good.
I said,
I'm
like an
glad that.
RP4 or something.
So class two deep bites are inherently difficult to treat prosthetically. And this one, there's so many other moving parts to it. Uh, what I would do is give this patient the option of saving the teeth. However, that would not include implant treatment. It would include a removable prosthesis. That's probably the best you could ever do there. Um, if you edentulate the patient, then were you planning on taking this impacted cuspid out?
That was the main reason I brought the case tonight.
Yes. So
Um,
so that is in a, I mean, theoretically, you could work around it. Uh, it's going to be a traumatic extraction to remove that. It's going to be very traumatic to remove it. So let me give you two options. One option would be to leave it and to work around it. What that would mean is that we couldn't have a canine implant, which we like to have. So we would have to overload that right side. So we would probably need an implant in 3, 4, and 5, then probably an implant in 9, 11, and then 12 or 13, and then 14. What's going on the bottom? Are you planning on doing anything on the bottom?
uh, at this point in time, no. We would look at the possibility of some an implant in the lower left side, but no.
Okay.
Her chief complaint centers around getting her maxillas figured out.
Okay. And when you say figure it out, is it more functional or is it more aesthetic?
More aesthetic, well, both. I mean, the existing prosthesis she has now, she's got a valplast with because of her high smile line, it clasps around the facial of her centrals. She doesn't like the look of it. It flops up and down. She's really not satisfied with a removable partial at
And,
all.
and, and how old is this patient again?
40, just a second, 48.
48. Okay. I mean, taking that canine out is an option. I would just explain to her that when you take that out, there's not going to be anything left there. And the possibility of placing an implant in that site is going to be questionable. So I would lean more towards not taking it out and placing implants, um, posterior and anterior to it. You already have one implant there that can be used. So I think that's a viable option. That would probably be the best. However, these teeth are going to need to be removed because there's pathology around them, and you're certainly not going to be placing implants at the same time. So, I if you're going to do an FP3 per se, then I would phase one, remove the teeth, uh, leave the cuspid, graft all those sites that I talked about 3, 4, 5, 9, one's already in 11. I would graft 12, 13, and then possibly 14 an implant later on. Okay. Another option would be to take that canine out. The only thing you would gain by doing that would be we could potentially place an implant in the number 11 position. But again, that's going to be iffy. If this patient was younger, it would be a different story. Um, there's there's not much buccal lingual bone around that cuspid. So you're going to have a through and through defect. It's going to be, very minimal wall defect. So it's going to be hard to graft that.
Okay. And the potential for an RP4
Yeah.
versus the
Oh, you could.
FP3.
Yeah. Yeah. So what I would do is get the teeth out, get her in a denture, start reestablishing a better occlusion.
Yeah.
And then while it's healing, start to discuss a RP4 versus RP3 or FP3. And then once you get the scan at 3 months, then you can work it up both ways and let her decide.
Okay.
So
Okay.
it might be an RP4 might be the best way to go here with a bar,
But they're
you know?
high, she's got a real high transition. And
Yeah.
so, I was just thinking more along an RP, and I could use that existing implant. So,
You can use that existing implant, yes. So, but
uh,
I would all give her the options, and that's going to be dictated on how this is going to heal, basically.
okay.
Okay.
Thank you very much.
Okay, Dan. Okay. Perfect. Okay. We have one more, do we?
Yes, sir. One more case, Dr. Resnick. It's for Dr. Pham. Doctor, would you mind unmuting yourself and presenting your case, Dr. Resnick, please?
Hi, Dr. Pham. How are you?
Yes, hi, Dr. Resnick. I'm good. How are you? I'm
Good, good. What do you
excited
have?
to be here. Thank you for having me.
Okay, great. What do you have for us?
I am a beginner. This will be patients very motivated. Will be my first time actually getting to place an actual implant.
Okay.
So I'm quite excited. I met her in 2024. She since then have lost 19, 30, and 13 was the most recent.
Okay.
She's all ready to start, and I'm just needing a little bit more of hand holding to make sure I'm not missing anything.
Okay, perfect. So, um,
I'm loading the plan right now, Professor. It should be up and running the next 5 seconds, sir.
So
okay.
she's 61 years old. Medical history is pretty good. I think just fibromyalgia and
Okay.
April for blood pressure.
Perfect. So,
Um,
Doc, right off the bat, do you remember me saying where's your first implant want to be? Upper
can you-
bicuspid.
yes.
So this is it. So let's see if usually there is bone here. So Hussein, do we have bone?
Yes, sir. We do
We didn't
have
lose
bone.
much of the buccal plate, so that's good. So let's look at his cross section. You placed an implant?
Yes,
Oh,
sir.
good.
I followed Dr. Pham. She's using a Bicon implant, sir, and that's the reason why I planned it this way. We have a 40 by 11 millimeter long implant over here.
Okay. Doc, did I hear that you use Bicon?
Yeah,
Um,
yes,
we
sir.
we were just introduced to it. We haven't committed to a system yet. We wanted to do Han because that's what we were trained with you. We
Yes.
just recently met an oral surgeon that is suggesting Bicon. So
Okay.
we thought we look into it, but
Okay. So you email me about this.
okay,
I would not buy Bicon.
you would not. Okay.
There's so many other good systems out there. There's too many
Okay.
limitations to this, and
Would you?
they're not easy to place. So
Okay.
I would not do that. But you can email me or call me, and we'll talk more about that. So
Okay.
Doc, this is your perfect first case. This is
Okay.
great. Okay. What I like about it, you have plenty of bone. Bone quality apically is not as great, but crestally it's a lot better. If we go ahead, let's look at the 3D model again.
Sir.
So, Doc, you have plenty of bone here. You can look straight up in there. There's no nerve. There's no um, area that you really have to be concerned about. You're anterior to the sinus. This is your perfect first case. So if this is going to be your actual first case, uh, let us know or let me know, and I'll walk you through it. I actually have a step by step for a first case that will just get you. It's just a checklist, but
Okay.
this is the one you want to do. just the upper, no more. Just do that for is your first case. Now let's look at, first of all, any questions on that upper?
None so far. I may have more as you walk me through the steps.
Okay. Okay. So I would do it guided. I will talk to you later about what type of guide, but that'll be a good one. Now let's look at the lower. And you said both sides, right?
Yeah, so 19 was lost July of 24, 30 was August of 24. Both of those I didn't do socket preservation. 13 was just lost in August, and I actually did socket preservation that one. Um, just because I didn't have the supplies ready. I met her on an emergency basis, so
Okay.
those caught me by surprise.
Oh, okay. No problem. So let's first look at just wait, it's coming up. Now,
Yes, sir.
if we look at Doc, again, where to start, it's always the maxilla because the mandible, even though you might think it's easier to use, the angulation's a lot more difficult, and usually we have the nerve to contend with. So let's first take a 3D image. He's going to, okay, remove the teeth.
Right away, Professor. Here we
So
go.
I'm going
Yep.
to have him. So see
Mhm.
on the left, Doc, you've lost the whole buccal plate there.
Yes.
The right is not that bad. So the right's better than the left. So let's look at the worst one first. Let's look at the left side and let's evaluate via the cross sections. Okay. Uh, yeah. So, Doc, you can see you lost 5 millimeters of the buccal plate.
Okay.
Yeah. So that has to be grafted. You just won't have enough bone. That needs to be built back up.
Okay.
Okay. So I would not even think of trying to place an implant, even trying to put one lingual, it's going to be too low. Uh, you build the bone back up there. That will be, do you remember we talked about the convex or a straight graft?
Mm-hmm.
Okay, this isn't a catcher's mitt, so it's a little bit more challenging. So you
Mm-hmm.
need just more tent screws, but you can definitely do this. This will be you'll have good access for it. Okay. What questions do you have for me on that one on the left?
Um, yeah, it probably would be just the approach for the grafting because that's not a catcher's mitt. So it's
Yes,
probably
yeah. And do you see? Show her how you've lost vertical height too.
Yes, sir.
So
Right away.
So look at on the sagittal. Yeah.
mm-hmm.
Okay. So see how that's come down. So when you place an implant, the crown to implant ratio is going to be more compromised. So even though we wouldn't graft in height that much, I think you'll get some just by building out the buccal plate. But this is a lot more difficult. So let's go to the other side. I think this one will be more straightforward. Did you
Here is
place
number
an implant
30.
in that one?
Yes, sir, I did. I did add an implant over here. It's 4 5 by 8, Professor.
Yeah. Um, okay. First of all, go ahead, put a longer implant in. Put like
So
b-
the
by like a
the
10
next in
millimeters.
the next in line, Professor, is an 11 millimeter long implant from Bicon. The jump is a little bit big, the
Oh
length of for
yeah.
Bicon. It goes from an 8 to an 11.
Yeah, that's the problem, Doc, right in itself. Their sizes are just
Okay.
very not easy to do. Just take that out, put a on 5 by 10
Yes,
in.
sir.
So, Doc, let's just look at a generic implant. Uh, we're going to just put a 5 by 10 in, and you'll be able to see it a little bit easier. That was going to be too close to the nerve, way too
Here you go,
close.
Professor.
Okay. So you can
Okay.
bring that up a little bit, Hussein. Tilt it a little bit more to the buckle. Okay. Okay. And is that still 2 millimeters or is that
Right now, we're at exactly 2 millimeters,
two
Professor.
millimeters? Okay. That would work right there, Doc. So a 5 by 10 would work perfect there, or possibly put an 8, make it an 8 and see how that looks.
Here's an 8, sir. An 8, giving us
Yeah.
4 millimeters, sir.
And that might even give us a little bit more. So let's go back to the Panorex. So Doc, here's what I'm going to recommend. Are you interested in doing the graft on this case?
Yes.
Okay. So here's what I think you should do. Let's do that upper first. That's going to get you in the doing implants. It'll get you psyched up and you'll love it. Then you can do the lower right.
Okay.
And then we'll tackle this graft. When you're ready to do the graft, contact Hussein or myself, and we'll work this up for you step by step on how to do it.
Okay. So
Okay.
13 first,
Yeah,
30,
the
and then
13
graft.
is straightforward, and that's going to be a very easy one. The mandible is going to be a little bit more challenging, but you'll be fine with that. And then the graft third.
Okay. So you're not going to try to graft and heal and then do the other ones.
Uh, well, for your first implant, I think doing that maxillary one is going to be enough for you.
Okay.
I won't put the patient. It will be. I think it'll be too hard for you. So I would just do the upper first. If you want, you can do the lower implant and the graft at the same time. You could do that. So you could do the mandible second appointment if you want to combine them.
Okay. Um, if you hands on had to pick a system, it would be Han then.
Well, the Glidewell is the easiest system to use, I think. Also, right now they have a new program where you get free implants. I don't know if you use Glidewell Lab, but if you place a Glidewell implant and then have the lab restore it, they give you a free implant. So you never pay for implants. That's pretty hard to beat. So I would say that is probably going to be your easiest one. I
Okay.
just I just had problems with a lot of doctors who place bicons and or who have placed bicons, and as Hussein showed you there, they don't even have a 10 millimeter implant. Almost every system has a 10 millimeter implant, so they go from 8 to 11. That's way too big of a jump.
Okay.
So yeah. Okay.
Okay.
But
Thank you so much.
you can reach out to me if you want, if you have any questions on that.
Perfect. Thank you so much. I
Okay.
appreciate
Okay.
it.
Take care.
You too. Bye.
Okay. Okay, Hussein, we did it and a
Yes,
little
sir.
bit over time. I thank you you did great work up on those. I thank everyone for staying on. I know everyone had a long day. We'll see you next month. Please get those cases in early because we do have a waiting list now. So try to get them in as early as possible. So everyone have a great night and a great rest of the week. Again, thank you to Dr. Robinette and Dr. Hussein. Take care.
Thank you, Professor. Thank you, everyone.
Okay. Good night.
Good night, sir.
Good night.